Hi, everybody, and welcome to tonight's webinar. We've got an exciting webinar tonight with Dr. Alain Aubé from Montreal in Quebec in Canada. And just before I introduce him, I'd like to thank you all for being on this presentation tonight. And for those of you watching the replay as well, this is brought to you on behalf of the Advance My CE platform, a platform recently formed to help dentists collaborate and work together to make their path from graduation to retirement as smooth as possible, without the distractions, without the speed humps, without the roadblocks that often have struck and very much distracted and destroyed some potentially great careers because of that. So we're here to help you make the most out of your career in private practice in dentistry. That involves bringing you great educators like Dr. Aubé tonight and others, both on our platform and in webinar sessions, as well as great companies for you to get the products that you need, both clinically and business and in your private life as well, so that you can have the most profitable life and live the life that you deserve for the investment that you've made, both in money and in time, in becoming a dentist and having a successful dental practice. If you need any details, you can just go to the website advancemyce.com and follow the links to join. It's free to join and become part of the dentist community there. Now, it gives me great pleasure to introduce Dr. Alain Aubé to present to you tonight. Dr. Aubé graduated from the University of Montreal Dental Faculty in 1984 and then underwent a tailored multidisciplinary residency program with special emphasis on full mouth prosthodontics and orthognathic surgery. After a few years of private practice, he continued with the full curriculum of the Dawson Centre, and from there he was introduced to Dr. Mark Piper and followed his complete program on TMJ pathology. In 2008, Alain founded the Canadian Occlusion Institute, an institute dedicated to teaching TMJ pathologies from a medical orthopedic standpoint, as well as diagnosis and treatment of occlusally related problems as well. He's recognised as the leading occlusion-TMJ expert, being referred to by prosthodontists, orthodontists and oral surgeons, as well as general dental practitioners. And Dr. Aubé still maintains a full-time private referral practice dedicated exclusively to TMJ and occlusion problems, and continues to teach and lecture intensively. It is our pleasure to have Dr. Alain Aubé presenting to you tonight. Alain, thank you for being on this webinar.
Thank you, David. Is it time for me to share my screen?
Yes.
All right, let's do that. Let's get that out of the way. And okay. Where's the presentation? It was, oh, there it is. Let me see if I can open it up. There you go. All right. Now, so again, thank you, David, for the opportunity of presenting this. A lot of dentists feel undertrained when it comes to night guards and occlusion in general. And so they actually feel undertrained in how to do them, how to present them to the patient, how to deliver them, what instructions to give to the lab. And tonight we're going to cover a lot of that. We're going to go through a little bit of an intro to find out what joint pathology is and how it actually affects the bite. And we're going to see, well, let me summarize things by saying that very few people today have a perfect bite. Our bites are off. We know that. We see it in our patients. We see it in our own, we feel it and see it in our own mouths. And there's reasons for that. And one of the main reasons, there are others, but one of the main reasons is temporomandibular joint pathology. And I'll explain what happens. We know about disc displacement. We've all heard of that. We've heard clicking patients. We know that exists. We've heard of locked patients because of the disc, but we kind of don't suspect how much of that is actually going around. And we got a beautiful slide on that. So we're going to see a bunch of cases today. The main part of the webinar tonight is going to be looking at cases and seeing how we can relate what we know about the joint, what we know about the mandible, what we know about growth and development, and the actual cases that are going to be shown. And you're going to see a lot of panoramic images and some MRIs so that you can understand what you see in the mouth and how that is actually affected, or how the mouth is the end result of a lot of different things going on, including what's going on within the joint. So we have this disclaimer we have to give. Participants should be aware of the potential risk of using limited knowledge when incorporating new techniques in their practice. Like today, I'm going to show you the delivery of a night guard. I'm going to show you how to adjust them perfectly. There are different types of night guards to be used that will be shown in the course if you eventually sign up for the course. We have courses to explain all of this in much detail. But tonight we're going to give you a couple of pearls on things how to talk to patients, and actually I'm going to show you an actual live delivery of a night guard. So you'll actually even know how to adjust them right off the bat. So, but be careful, if you don't have the whole course, you may weary into areas you may not want to. Now, I do not have any commercial ties. If I speak of a product during the webinar, it's because I use it and I like it. I am not paid to speak of anything. So I have never had a commercial link. I never will be. I absolutely, for my own self, need to stay totally independent. So the eyes can't see what the brain doesn't know. And I don't know, I don't remember where I found that from, but I loved it when I saw it, because this is what this course, this webinar, and the whole course is all about. When you look at mouths, most dentists just look in the mouth and are trained to treat, I should say, teeth and gums, but as individuals, not as a system. And when David presented me in my intro a little bit earlier, he said that in my residency program, in my first year as a general dentist, the residency program was tailored to full mouth, crown, and bridge, and to orthognathic surgery. Of course, I wasn't the surgeon, I was the assistant. But I did at least 30 orthognathic surgeries, Leforts, and mandibular advancements. And all of that kind of put in my mind, got me into a different mindset from what I had in dental school. And as I was saying, in dental school, we're taught to do things tooth by tooth. And that is a good way of doing things. But at one point, you have to kind of take a step back and see the bigger picture. And when you are introduced to full mouth, crown, and bridge, and even more so when you're introduced to orthognathic surgery, you're actually introduced to the system and how the whole thing must function together and relate together. And already there, even though I went to Dawson and Piper and learned about the joint in detail later on, even at that stage, the surgeons operating on the mandible knew that a short ramus came from a small condyle, didn't really know why and how that happened back then, but they knew that bites were off because of poor joints. We already knew that, and that was like 1985. So that's like, what, 38 years ago. And so we learned more with time, and I'll go into a little bit of detail about what's happening in this webinar. Now, so basically what's going on in the joint is affecting the bite. And we know about disc displacements, but do we know how often they happen? And do we know that when the little disc slips forward, it competes with the condyle for the space within the fossa? So as the disc slips forward, the condyle slightly retrudes. And so you get a development or the early development of a class 2 type bite. So the bite can actually become slightly class 2-ish from a simple, very minor disc displacement. And when the disc displacement happens, you can have poor growth of the condyle. That's a known fact now. It's in the books now. So when the disc displaces at a young age, typically because of childhood trauma, well, not we, but they have MRI'd young kids at the age of around 6 months, found that all discs are in position. But we'll see a slide a little bit in a few minutes that when you're a teenager, pre-orthodontic, and you need ortho, you have a high chance, and we'll see the statistics, a high chance of having a displaced disc. So we know from that comparison that childhood trauma is actually the main cause of disc displacement. And it's then that it happens. And that's why adolescents have these twisted bites. And that's how the bites get off starting in childhood or late childhood and early adolescence. And this is one of the causes for the need for orthodontics. Now, of course, there's the airway. Of course, there's the breathing and there's the tongue and all of that. But the joint is also at the origin of a lot of the problems, or it is at least a cofactor in most of the malocclusions. And we'll see how that happens today. And you'll understand, by the end of this webinar, you'll see what I'm talking about and you'll understand that quite well. So one of the main goals of this webinar is to put things in your mind so that when you look at a mouth, you understand a little bit more how it got to that state. So I was saying that we look at mouths, we're taught to look at mouths and just accept the facts, but there's more to it. Sorry, there's more to it than that. So um, I remember Peter Dawson, one of his phrases he loved was, when there's an effect, there's a cause. So look for it. And when we look at mouths, if we understand how they got that way and we understand the causes, we're equipped to treat better, but we're also equipped to help the patient understand what's going on in their mouth and then the need for occlusal protection. Like just today, I had a patient, a woman, walks in, and her bite is off, maxilla is thin, mouth breather, maxilla is thin, maxilla is actually short, little bit class 3-ish actually in her case. And the bite's off, and she's got tension, and the joints are degrading because the bite's off, and it's forcing the joints, and there's a little bit of degradation there. And I explained how all that happens and how all that leads, how the bite that's off actually leads to stress in the system. And by the end of this 3-4 minute explanation, I have a software and I have animations to show things. By the end of this 3-4 minute presentation, she actually said, "Oh, now I understand why you need a night guard. My dentist had said, yeah, I need a night guard, but I just said no, and that was the end of the conversation." And that is the end of the conversation for a lot of patients. They say no, because they just didn't understand fully why they needed the night guard. And so for the dentist to understand what's going on in the mouth, how destruction happens, where it comes from, it is just so much easier to explain to the patients why they need the night guard. And well, of course, I've been doing this for a long time, so all patients say yes. I mean, no one says no. They may not have the financial means to afford one sometimes, sometimes they postpone or they don't say yes right away. But in their mind, once they understand, the answer is yes. They understand what they need and why they need it and the benefit to them. So putting things in your mind and putting things in your brain, in your knowledge today is the goal, so that when you get to your patients on your next work day, whenever that may be, you will have more in your mind to understand what's going on, and you'll be a lot better equipped to talk to the patients and eventually to help them understand why they need the night guard. Now, life is stressful. We all know that. And stress, of course, is part of the factors that affect the jaws, clenching and tension and everything. Now, life is stressful, but for the dentist, making, delivering a night guard, and for the patient wearing a night guard, all that shouldn't be stressful. There's simple ways to do things. We're going to see that again later on, but making a night guard, so taking the impressions, taking the bite should be no more than 10 minutes. Delivering the night guard should be no more than 10 minutes. Now, you give yourself a 20-minute appointment because you have to say hello and goodbye. But actually delivering the night guard is no more than 10 minutes when things are perfectly planned and you know what you're doing. Good impressions, good bite, do it with a leaf cage. We'll explain that later. And the lab knows how to do the proper adjustments on the guard. We'll talk about that later too. So when we do the type of night guard we're going to be talking about tonight, it is much more comfortable for the patient because of the way it's adjusted in accordance to the body's physiology. That's been studied, that has been totally studied now, and there are a lot of papers out there. We know what the proper bite should be. I'll explain that a little bit later on in the lecture. So basically, again, life is stressful. Night guards should not be, and we're going to make it simple for you. Now, okay, who should we be making the night guards for? Well, I kind of introduced that a little bit. Now, present day Homo sapiens has a much smaller jaw than Cro-Magnon had. Now, what happened? So there's a beautiful article in the journal called Scientific American. It's a journal that's been around for a long, long time. And they will have scientific articles, but made for people, for general people, for normal people to understand. So everyone can read that and understand the science that's being dealt with in these articles. And there's an anthropologist by the name of Peter Unger that wrote an article that was published in Scientific American on April 1st of 2020. It's fully available online. You can see it for free. It is a beautiful read. It is titled, "Why We Have So Many Problems with Our Teeth." Please read that. It's a 15, 20-minute read, no more. And it is just so interesting to see dentistry explained by an anthropologist. I mean, seriously, this is the person that explained the best I have ever seen why we all have so much work to do today. It is just a little, it's a, in French we say a bijou. It's a jewelry, a little jewelry piece of an article. So please read that. But basically what we learn in that article is that the jaws are getting smaller, and this started only 250 years ago. And what happened apparently, the explanation they give is that at some point we became non-chewers. So Cro-Magnon only had hard, dry food to chew. We have soft, cooked, mushy, wet food to chew. So our jaws are not developing as much. And so there's weaknesses that are starting to happen within the system. And the most important weakness that we've seen is the ligaments that tether the disc. So the ligaments that retain that disc in place are now weak, and that seems to be genetically transmitted. And because these ligaments are weak, we're much more prone to having that disc displaced with much lighter, gentler injury. So the child I have in my patient base, that's the earliest clicker, is 16 months old, was 16 months old, because now he's like 3 years old. But when he was 16 months old, his mother brought him to me because he was just playing on the ground, hands and knees, fell, delicately hit his chin, almost didn't cry, did not have a scar, nothing. But the mother said that was in the morning, and at lunch, I heard this clicking sound when he was eating, was wondering what it was. And I put my hand and I felt the click in the joint. So she brought him to me, and lo and behold, he displaced his disc, has a reducing disc, but there's a click. And that will lead to a more class 2 bite on that side unless it eventually heals, but that's not typical. Typically, once those ligaments are injured, the disc slips forward, the biting, the chewing is actually done on the retrodiscal tissue, on the ligaments, and that stretches them out slowly, slowly, more and more. And eventually you just get a more displaced disc and a more retruded condyle and a condyle that doesn't grow, and you get a class 2 on that side. So anyways, the article is beautiful. It is very well written, easy to read. It is just fun to read, actually, for a dentist, to see the point of view of Peter Unger, the anthropologist. So, which one of these two needs a splint? Well, it's clear, and Homo sapiens is a stressed out person. So maybe Cro-Magnon was. I don't know. I don't know if stress is genetic or if it's just acquired through the environment. But definitely today we need the night guards because our bites are off. We have interferences in slides, and they will definitely stimulate muscle tension. And that was published for the first time in 1983 in the Journal of Prosthetic Dentistry. Now, under Williamson and Lundquist. So Williamson and Lundquist, Journal of Prosthetic Dentistry, somewhere in 1983. The relationship between the teeth and muscle tension. So, this is important. This article was published already 24 years ago in December 2000. This is published by Brian Nebbe, which is an orthodontist. They published this in the Angle Orthodontist, which is a good orthodontic journal. And Brian is an orthodontist affiliated with the University of Alberta, or was. I don't know if he still is. And he did his ortho work, and most ortho work is done early adolescence, and joints start cracking and headaches start and joints start hurting later adolescence, so 16, 17, 18 versus the 13, 14, 15 where the orthodontics are typically done. And at one point, he was sick and tired of all these youngsters coming back to him and the parents coming back to him saying, hey, you did the orthodontic treatment on my child. They did not have a headache before. They did not have these clicks before. And now, like 6 months or a year, 2 years down the line after your ortho treatment, they've got clicking and they've got pain and they've got muscle tension. It's your fault. And he said, well, I don't know if it's my fault, and I'm not sure, and I don't think so. But after having that come to him a lot of times, he said, okay, let's see if we can find a way to check this out. So he thought, how could we know if the joint problem was there prior to the orthodontic treatment? So he teamed up with the radiologist that was there, and the radiologist there was David Hatcher. David is an American that had moved to Canada and was working with the University of Alberta. And he said, well, yeah, sure. All we got to do is do an MRI of the joint before and do an MRI later on and see if there's a difference. But let's do MRIs of these joints, these patients, this population that needs ortho. And let's do the MRI before the ortho and let's see if these discs are in place or if they're displaced. And lo and behold, look at what happens. Like if you were a 13 to 15-year-old boy in the end of the 90s and you needed ortho, well, if you look at the statistics here, in your left joint, you had a 60% chance of having a displaced disc. The 40% is the normal disc. So there's only 40% of discs on the right side of 13, on the left side of 13 to 15-year-old boys that are in place. On the right side, it's even worse. Only 36% are in place. Now, if you combine those two statistics, if you're a 13 to 15-year-old boy in need of ortho, you have an 80% chance of having at least one of your discs out of place. That's a lot. Now, at least I think it's a lot, or I feel it's a lot. Now, let's go to girls. This is horrendous. Only 27%, 1/4 of the joints on the left side have their disc in place, and 1/4, 23% have their disc in place on the right side. Combine those two statistics, if you are a 13 to 15-year-old girl in need of ortho, you have a 90% chance of having at least one disc being displaced. That means basically they're all displaced. And let me emphasize that this was the MRIs that were available in the end of the 90s. I don't know if you know MRIs or not, but the power of the machines has tripled and quadrupled and more since then, and we have much, much, much higher resolution today. Back in those days, the resolution was very low. So they found displacements, and I'm like totally convinced that if you did the same images today, you'd find a lot more because your images are a lot more precise. So in any case, these numbers are high enough for me to accept. And basically, a lot of those kids that need ortho have displaced discs, and the displaced discs are at the origin or of at least part of their class twos. This is a really important article. You should read it. And this is at the base of a lot of stuff we're doing today. And starting then, joint pathology was starting to be addressed and starting to be looked at. And about 20 years, 15, 20 years after this article was published, David Hatcher, the radiologist, came out with the first book on temporomandibular joint pathology. It's called Specialty Imaging the Temporomandibular Joint. David wrote it edited it with Danya Tamimi, another radiologist. And they had about 40 university professors write the chapters, and they edited the whole book. And it was the first book, an 850-page book on joint pathology. And now they're in their second edition, and it's a 1,200-page book now because it includes sleep disorders. So it's now called Specialty Imaging the Temporomandibular Joint and Sleep Disordered Breathing. And you will understand growth and development with this book, and you'll understand joint pathology and how it all affects growth and development and all the malocclusions we have. So the joint has a role to play in a lot of them, not all of them, but a lot of them. It's worth looking at that book. Now let's go through a little bit more of that. Now, we know that the literature is clear. A new interference can potentially generate muscle hyperactivity. Now, if you have a displaced disc and your mandible skews to that side, you have an interference happening automatically. The cusps are not aligned anymore, and there's an interference happening there. As that child grows, if the maxilla grows and the lower jaw doesn't grow quite as fast or doesn't catch up, you're having a new type of interference every single week, or every month. So when you have a growth discrepancy between the top and bottom, you actually have new interferences happening on a regular basis. And this is felt by the body as if a patient had a new crown or new fillings every week or every month. And this is one of the possible causes of clenching and grinding. It's one of the stimulants to clench and grind. The body actually wants to erase that, but the interferences keep happening because the growth deficiency or the growth difference between top and bottom keep happening and keep progressing, and the body can just not follow up and grind away those interferences as they happen, even though it tries or may try. If you look at the left side of the screen, you'll see a diagram with the condyle and the disc, and you have the fossa and the eminence. Now, in the middle, you have a cadaver cut where you have the condyle on the bottom, the fossa and the eminence, and you have the disc way out here in the middle. It's an hourglass laying on the side type of shape. If you look on the right side, you have a mirror image of these two, but this time in an MRI. And if you're not used to looking at MRIs of joints, you have to kind of imagine that a 5-year-old took a black felt pen and drew a black line over all the white lines we're used to looking at on X-rays. So basically what I'm looking at here, this is the outline of the condyle. So this black line is actually the cortical bone layer of the condyle, and the gray inside is the condylar marrow. The fossa, this is the tympanic plate, and this is the outline of the fossa and the eminence. So it is a black line because it is cortical bone. So I hope you can see the space between the condyle and the fossa up here in the eminence. And between the two, on the more anterior side, this black area and the middle line in the middle, and this black area here, this is the disc. Now, this is a normal joint. Now, personally, I don't get to see many of these because I treat basically people with bad joints or poor joints. So I'd like you to look at this because we're going to be looking at people and we're going to be looking at a lot of cases. Like tonight, part of the presentation is actually going to be cases. Actually, the main part of the presentation is going to be cases. I'm going to show you people, show you how all of this happens, and show you the end results. Now, the condyle here is normal, meaning it has grown vertically, it has grown anterior-posteriorly, it has a nice round shape at the top, it has a nice light angle, somewhat similar to a hockey stick. And it's just basically the marrow is relatively uniform grayish like it is now, and this is basically a nice healthy condyle. Now the disc up here, if you consider the fossa as a clock, you will see that the disc, the most posterior part of the disc, we call the posterior band, ends at what we would call about 1 o'clock. Now, normalcy is considered from anywhere from noon to 1 o'clock, but anything ahead of noon, so 11:30, 11, 10:30, 10 o'clock, 9 o'clock, these are all displaced discs. And please make a mental image of this joint because it's the last normal one we're seeing tonight. All right. We're going to show you a cadaver cut, a video of a cadaver cut with the disc in place. So this is the condyle going forward with a disc in position, that's seated condylar position. And this is translation, so that's either open mouth or protrusion or lateral protrusion if you're considering just one side. And this disc is fully in place. You have the retrodiscal ligament, the lower one here, the superior one there, and they're totally strong and tight, and they bring the disc back in position. Actually, they hold the disc when it comes forward. They prevent it from slipping out forward. So this is the normal relationship between the condyle and its disc. And this, in adults today, at least in my patient base, is less than 2% of joints. Now, the next stage in disc displacement is anterior disc displacement with reduction, which means the ligaments have been stretched in the back, the disc is somewhat forward, and the condyle actually comes back underneath the disc as the mouth opens, and that is what produces a clicking sound. So the disc is out here, and as the condyle slips under it, you'll hear the pop. You'll actually see the pop, and in a patient, you can, in most circumstances, hear the pop. So you'll see that again many times, actually. As the condyle pops under the disc, you get the infamous click. So this is what happens when a patient clicks. The retrodistal tissue is pulled over the condyle. So when the condyle seats, there's still some tissue between the condyle and the bone, so there's no bone-to-bone contact yet. And there's always some disc interposed between the condyle and the fossa, or the posterior slope of the fossa and the eminence. And so basically the condyle is relatively protected. However, when the disc is displaced in this manner, we oftentimes start seeing growth defects in the condyle for a couple of reasons I won't explain tonight. It's a little bit long to explain, but there are a couple of reasons that the condyle slows down its growth, or actually sometimes stops growing when the disc is out of position. Third stage is the anterior disc displacement, but this time without reduction, which means there's no click. So the condyle is actually just pushing the disc out. The disc is already out forward, and as the condyle translates, all it does is push the disc even more forward. The retrodiscal tissue is still over the top of the condyle. It's still covering the condyle, and it's still preventing any bone-to-bone contact. However, that tissue is relatively fragile, and anyone that clenches a lot will eventually, or has a high probability or a high possibility of eventually going through that tissue and eventually having bone-to-bone and having osteoarthritis develop. So here, this is the type of patient that typically used to click and now stopped clicking. So they clicked for a number of years and eventually stopped clicking. Most of those patients did not get better. They actually just got worse. They think they got better because they're not clicking anymore. Well, actually, the whole joint degraded a little bit more. Condyle went up a little bit more in the fossa, and they actually retruded their jaw a little bit, and they had a bite change. They may or may not be conscious of the bite change, but they obviously had it. End stage is when the retrodiscal tissue is perforated, and you get bone-to-bone contact and severe osteoarthritis. If you look here, we're in the other direction now. So the disc is this little ball bunched up in front. This is the capsule over here. The condyle has severe osteoarthritic damage. It's totally flattened out, and so is the eminence. So this is the end stage of this disease. Some of these joints can be stable if this happens slowly. I've seen this in 16-year-olds, and they've needed a prosthetic replacement of the joint. We'll see one of those cases later on today. Now, we can look at the same on an MRI. So we can now actually appreciate what this looks like on an MRI. So in the middle here, we have the condyle, we have the fossa and the eminence, and we have a disc that is relatively in position. And this is a cinematic view. So you'll actually, as I press the button, you will see the condyle move on its disc on the MRI. So this is normal function of the condylar disc assembly. So let's go back and let's do that again. This is what we just saw in the cadaver cut, but this is on the MRI. So you can see just the condyle and the disc flowing together and working together. So this is a disc which is in position. Next image, here we have the condyle, again, the fossa and the eminence, and the disc is this kind of butterfly shape here. It looks like a diluted ink blot or something, but it's a butterfly shape, and that's the disc. So right now the disc is in front of the condyle, and as the mouth opens, you will see the condyle slip under the disc. So this is the click. So it's the anterior disc displacement with reduction. So you're seeing the condyle slip under the disc from behind the disc to under the disc, and this is anterior disc displacement with reduction. And this is the habitual click that people have. Here we have the condyle, and we have the disc out in front, and the fossa and the eminence, of course. And this time the condyle is just going to push the disc a little bit further. So this is anterior disc displacement without reduction. So as you can see, the condyle is just pushing the disc further out. However, there's no bone-to-bone contact yet, so you're not having osteoarthritic damage, at least not yet. In a heavy clencher, this will eventually perforate, and you will eventually get bone-to-bone contact and osteoarthritic damage. Here we have, this one is a little bit harder to see. So you have the condyle up here. So this is the outline of the condyle. So all of this is condyle. You have the fossa and the eminence, and the disc is this kind of triangle shape out here. And as I start the animation, you're going to see the condyle just push the disc, but you're going to see the bone-to-bone rubbing together. And this is severe osteoarthritic damage, and these patients don't click. They actually will tell you they have sand in their ear. So they feel sand in their joint, and this is, when they have that feeling, it's 99% of the time osteoarthritic damage, bone-to-bone rubbing together. Now, we've illustrated this in diagrams. So this is the normal condylar disc relationship and function. Let's do one more time. And now let's go to the degradation phases. So we're going to go through, in this animation, we're going to go through all the degradation phases. So disc in place, ligaments stretch out. There's no click yet. This is just a minor disc displacement. This is the click stage. So goes over the posterior part of the disc and you have a click. Eventually leads to a non-click and a non-reducing disc. Locked jaw, this is often the case. And eventually it perforates, and then you get the bones rubbing together, and you eventually get the osteoarthritic damage happening. I'm going to play that back one more time. And this time, instead of looking at what happens just in the joint, I'd like you to look at the condylar position. And I'd like you to imagine what's happening to tooth position at the same time. So let's play that back again. Now, as you can see right now, the condyle is centered in the fossa. But as the disc displaces forward, the condyle is going to go back a bit. And as the disc totally vacates, the condyle is going to come more back and eventually forward again, but up. So we're going to end up with a condyle and no space between the fossa and the condyle. And the whole mandible is going to retrude as all of that happens. And your bite is becoming more and more class 2 on the affected side or sides. So now, as the disc goes forward, condyle goes back a bit, creating a little bit of a class 2. And as that accentuates, you're accentuating the class 2. And then you get the click. Then as the disc keeps on moving out, condyle has started going back up, but this time deeper and deeper into the fossa. And that is also creating a mandibular clockwise rotation, which is eventually leading to either a more severe class 2 or very oftentimes pivoting around the last molar, you get an open bite in the front. In a young patient, if you have a 16-year-old patient with an open bite, 90% of the time, this is the joint status. So if you have a young patient with an important open bite in the front, most of the time, this is the joint status for them. Now, if you look at the images here, you'll see that the occlusal plane is skewed. It's higher up on the patient's right side. And if you look at the joint, there's almost no condylar head left. You have a neck of a condyle, but no condylar head. On the other side, you still have some condyle. Now, on the left side of the screen, but on the right side of the patient, the coronoid process is higher than what's left of the condyle. In the other image on the other side, the condylar process is lower than the top part of the condyle. So this side is not affected or much less affected. So the ramus total length from head of the condyle to the angle here is much longer than the other side where it's much shorter. You have a much squarer angle here and a much more open angle here. Now, the fact that this is short, this is higher up, where's the bite? So the teeth could not erupt completely or actually eventually re-intruded. So if this happens in an 8-year-old, you will not have total eruption of the teeth. Here you got total eruption, here you don't. If this happens later on in life through osteoarthritic damage, you're actually going to get contraction of the alveolar process through intrusion of the teeth. And you're eventually going to get a short side. And as the mandible deviates to the patient's right side, this is a severe case, you're actually crossing over to a crossbite here. And this side is actually a little bit open. And if you look right under at the TEC scan image, you'll see that the bite force is like 75% on one side and like 1/4 on the other side. So because the disc vacated and the condyle here either didn't grow or eventually melted away from osteoarthritic damage, the bite totally shifted to that side. And all the occlusal pressure is here. So the problem we're having in these types of cases is the following. When the disc slips out a little bit, this side goes back a little bit, and you're getting a little bit more pressure on this side. If you're getting more pressure on this side, with a dislocated disc or slightly or partially dislocated disc, you're actually applying more pressure from the condyle to the retrodiscal tissue behind the disc. As that pressure is applied, it's going to push into that tissue and slowly push that disc further and further out. So the pattern that's happening is that the more degradation you have here, the more skewing of the bite to that side you have, the more pressure you have on the teeth, but the more pressure you also have on the joint. And as this gets worse, you have a vicious circle going on, because the more this degrades, the more the bite's going to shift to this side. The more the bite shifts to this side, the more force is applied on the joint, the more it will degrade. The more it degrades, the worse this gets. The worse this gets, more force, more degradation, and you eventually end up with a patient looking like this. The patients we're going to see later on in the presentation are all different levels of this same phenomenon. And splints and bite adjustments come in here. When we make a splint to this type of patient, we want to even out the pressure. So we're actually reducing the level of pressure on the condyle here. So the goal of the splint isn't to cure the joint. The goal of the splint, and this is an orthopedic principle, I don't treat TMD. Like TMD is known to be temporomandibular disorder, and people think it's pain, and it's just pain, it's for stressed out people. That's not what I treat. I treat temporomandibular pathology, temporomandibular joint pathology. This is pathology. This is not just stress. This is actually a pathological joint leading to a bite that's off, leading to excessive muscle force being applied, leading to tense muscles, leading to headaches, leading to broken down teeth, leading to abfractions, leading to tooth mobility and tooth fracture from a dislocated disc. Something that started as a very simple dislocated disc, but the thing just went haywire and it just broke down totally. Now, all patients don't break down this bad. We understand that. But most of our patients are some minor version of this. And the splint, if it comes in early enough or at the proper time, can prevent a lot of this from happening. 5 years ago, I published an article where we took a series of patients with osteoarthritic damage of the joint. And basically what we were looking at was condyles with perforations in the top, meaning the cortical layer was eroded and perforated. Using a night guard, we had a high percentage of patients that had reformation of the cortical layer. So we actually had healing of the osteoarthritic damage. We didn't have growth of the condyle. We didn't get a new condyle, not at all. But at least we were able to stop the process by distributing the bite on the night guard in a manner where the excessive force on that condyle was reduced to a bodily manageable level. So the goal of a night guard is actually just to redistribute forces. It's to make it viable for the patient, make the force application viable for the patient so that the teeth stop having so much stress, the periodontium stops having so much stress, the joints stop having so much stress, and the muscles stop working in pairs that are not coordinated. So the night guard serves to reestablish what should be there, should have been there. All right. So today, most bites are off. And we know that because we look at these mouths all the time. And actually, how many of you, I don't know, depending on where you are in the world, these numbers may be different. But in North America, 90% of the population is class 2 or class 2-ish. A study by the British Army that was started in the early 1900s after Dr. Angle came out with his classification. The study was done because the people, the dentists in the British Army said, hey, what are our soldiers? Are they, like Dr. Angle says, there's class 1, class 2, and class 3. So our 20-year-old young men in the Army, what are they? And the study came out saying that they were class 1 with a 10 to 15% overbite and the teeth were touching. And 80 years later, somebody read that article and said, "Hey, that's not what I'm seeing today. Let's have a look at our 20-year-old soldiers now." And basically 80 years later, the average was slightly class 2 with a 50 to 60% overbite. So in a short period of time relative to humanity, 80 years, there was a significant change in the 20-year-olds' bites in the British Army. And that's what we're seeing in North America and in many parts of Europe. So we're seeing bites that are off and they're class 2-ish. Actually, beautiful class 1s that grow naturally without orthodontics, without any intervention, are a very small percentage of the population. And class 3s, which are, as we know now, mostly subgrowth of the maxilla, actually are also a low percent of the population. Maybe it's 5%, maybe it's 2%, maybe it's 10%, wherever you are. Again, the numbers can be different, but the percentages of population that are truly class 1 or truly class 3 are much lower than what are today class 2s, actually. Now, by the way, we have systems that are breaking down, but at the same time, we all have stress issues. I mean, who today doesn't have a stress issue? I mean, very few people. My patient base, 30% of the patients I see are actually on meds for stress and anxiety. And that reflects what's going on in the general population in North America. Again, I don't know what the status of that is elsewhere in the world, but here in North America, this is absolutely incredible. I mean, almost 20 to 30% of the population is on meds for stress and anxiety. So stress is also a factor in the development of poor bites and of problems associated with poor bites. And it's actually just another factor to dial in that makes for more and more breakdown of the different elements of the system. So what do you see in patients' mouths? Well, you see attrition, cracked teeth, recessions, abfraction, mobility, sensitive teeth, tense muscles, headaches, neck pain, painful joints. And where does all this come from? Well, we just pretty much explained that. And what percentage of your patients have these effects? If you look closely, the answers I typically get when I give these lectures, and I've given them all over the world, is that, well, most of our patients do have signs. Now, let's go to the case presentations. This is less dry and a little bit more fun for most of us. Case 1. Okay, this is a 59-year-old lady I treated a few years ago, maybe 8 to 10 years ago. And as the diagram we saw just a couple of, the CBCT image with the tick scan we saw just a minute ago, her jaw is skewed to the other side, but this could have been her on the other side. So ramus is short on her left side, ramus is long on the right side, chin is higher up on her left side, ramus is short, ramus is much longer. She came in because she lost 2 upper molars on the same side. Can you guess which molars that was? Those were, so it's the first and second molar on the upper left. International number would be 26 and 27. In the US, let me count that quickly, that would be 14 and 15 if I'm right. So anyway, she was missing 2 teeth on the top left, those 2 molars. And she had a little bit of work. She had clicking and crepitus in her joints, already had some sort of bite adjustment, wasn't completely done. And she says, my body feels unbalanced. Well, I can wonder why, because your head is skewed. Now, this is her bite. Now, that top picture here, the picture is not crooked. That's her occlusal plane. That's how bad it is. And you can see that this side is short and this side is a little bit longer. And of course, all of this is higher up. Now, this is her teeth. She has a history of no cavities from bicuspid to bicuspid, no restorations except for bonding here to, hide the class 2, div 2. Small restorations here, crowns on the lower first molars and nothing here. And the history of these two teeth is they had the exact same thing as this when she was young. And eventually the fillings cracked, the enamel around the fillings cracked. She had the fillings redone. They eventually did composite resin, telling her, like we used to do in the 90s, that the composite resin was going to hold the teeth in place and it was not going to, teeth were not going to fracture anymore. But of course, we know how true that wasn't. And the teeth continued to fracture. So she had two crowns made. And as her bite shifted to that side, as the condyle degraded, the bite shifted to that side, the porcelain diffused metal crowns, actually the porcelain chipped off. And as these teeth kept banging onto the metal underneath the porcelain, they started being painful. So she had two root canals, two posts and cores, and she had two new crowns put in. And as the bite kept skewing to the left, she eventually had fractures of the roots and eventually had extractions. And now she was consulting because she said, well, the dentist wants to make implants, but he wants to make sure they're going to survive. Well, I'm sorry, ma'am, they probably won't. Now, this is her panoramic image. On her right side, condyle is of relatively normal height. It's equal to the coronoid process, which is a little bit suboptimal, but it's still better than the other side, where the coronoid process is way high up compared to the condyle. So this has severe osteoarthritic damage that progressed through the years, and this is the origin of the loss of these two molars. As the bite shifted to her left side, the pressure, as we saw in the TEC scan image, was more and more on the molars here, and eventually they just broke until they were extracted. So do you think this patient would have benefited from a night guard early on in her life? Now, maybe she was told to wear one, maybe she wasn't, I don't know, I wasn't there. But if she had one that was fully equilibrated and well adjusted, this probably would not have happened. If her bite had been adjusted at the same time, there would have been a lot less pressure both on the teeth and on the joint, and possibly this would not have degraded as much. All right, so this is an image I like to have in my mind. When I look at a patient's bite, when I look at their teeth, when I look at a bite, I basically look at how the teeth are set, and I put that over the panoramic image I can see. And this most instantly gives me an idea of what's going on within the system. So when I see a skewed bite like that, where the occlusal plane is totally canted and the left side is high up, I don't even have to look at the panoramic image. I know that joint's bad because that's how that happens. On the MRI, you can see, let me outline that this is the ear canal. This is the tympanic plate. This is the outline of the fossa and the eminence, way up here. This is the condyle, so it kind of looks like a dog head from the side. So this is the outline of the condyle. You can see that the cortical layers here are very thick, and up here they're very thin. This is the disc bunched up way out here. So this is a non-reducing disc. This disc is totally out, and as the mouth opens, the condyle just pushes the disc further and further out. This condyle, however, retained its length. It is still pretty sizable. Now, on this side, the condyle is much shorter. It's had much more osteoarthritic damage. This little ball here is called osteochondritis dissecans, so that's another problem we'll talk about in another lecture. But the disc is also here totally out of place, and this too is a non-reducing disc with bone-to-bone contact. Now, this one was more affected than the other one. So somehow the bite skewed to this side, and eventually the pressure on the bite, pressure on the condyle became greater on one side, and that vicious circle set in, and you now have this type of effect. All right, this is just the outline so that you can actually see what's going on, because most people, again, I put that there because we're not used to looking at MRIs. So you can follow the outlines of the condyles and of the disc and have a quick look at that back and forth or up and down. All right, case number 2. This gentleman. This gentleman was a heavy clencher, had a rehab a number of years ago. And this is what the rehab looked like now. So he came to me saying, well, I got a lot of headaches. I'm clenching all the time. I have sinus problems. I have to take medication to clear my sinuses every single day. That medication dries me up. So my nose is dry, my mouth is dry, my eyes are dry, and the teeth are breaking down. I don't like the looks of it anymore, and I'd like to have this changed. And you can see that he's very deep bite. Now, some patients are chompers, they chew up and down. Some patients are side chewers. And if you get a side chewer with a deep bite like that, it's, I mean, it's a concoction for destruction and what's happening here. I mean, this patient chews horizontally in a deep bite, so he's breaking everything. So we decided to do the rehab, but to give him an anterior disclusion that would be much more in line with his chewing pattern or his bruxing pattern. So if you look at his condyles are good. I mean, they're nice and strong. I mean, the cortical layer here is nice and thick. You can see it on the panoramic image. Condyles are higher up than the coronoid process, much higher up than the coronoid process. So these are big, healthy condyles. However, you can see that the antegonial notches are deep. You can see the bone sparings here coming out. So you can actually see that this is a heavy clencher as well. Now, wax up was made, and as the mandible is slightly retrusive, we had to extend the incisal edge to make an incisal surface. So if you look at the temps, you can see that we have an incisal surface. So basically the lower teeth are contacting at the lingual edge of this occlusal surface, of this incisal surface, I should call it. And it doesn't show from the front. These are the temps, of course. It doesn't show from the front, but if you look underneath, you can see that this is basically an integrated night guard. So that was a wax up. You can see that we give canine guidance on one side and canine guidance on the other, and eventually incisal guidance going forward. And this is the end result. And there was no periodontal work here. This is strictly opening the bite a little bit and getting the contacts to be where they're supposed to be and getting the disclusion to be very, very horizontal. So we open the bite and thicken the lingual to get the bite to be much more equal to his bruxing and chewing pattern. So again, canine guidance to one side, canine guidance to the other, incisal guidance to going forward. Of course, this is much better looking and much healthier than this. This was 15 years old and was broken down. This was done 5 years ago, and there's been no breakage yet. And again, much better smile on this side. So aesthetically, it's much more pleasing, but also functionally, it's much more pleasing to the point where the patient wrote us a letter and told us that now that you've given me this functional bite, and if I can describe that functional bite for you, it is the Dawson bite, or the now Okeson bite that Okeson calls the orthopedically stable bite. Now, the orthopedically stable bite is a bite in which you start with the seated condyles and then you seat the canines, and the posteriors have to not interfere, which means they can touch exactly at the same time, but you don't want any contact of the back teeth to create a pivot or an interference or a slide between the seated joint and the seated canine. So you want it to be smack onto the canine. And again, the posteriors can touch lightly, or they can touch gently at the same time as the canine, but cannot touch prematurely. And this is true on the night guard as much as it is on a rehab. So this is occlusal correction, and this is bite correction through rehab. So the orthopedically stable bite is seated condyle, seated canines, canine guidance going forward, incisal canine guidance going sideways, sorry, and canine guidance going forward. And it's just the bite we learned about a long time ago, but it's just a question of how do we produce it in the mouth and how do we give this to the patient with the most horizontal possible function, so that if they do clench or brux, they'll actually be sliding in a pattern that's convenient for them, and they'll have much less muscle tension and much less destruction going on. So the patient sent us a letter saying that, well, his taste is better and so is his smell, probably because he's not so dry anymore, because he's not taking these sinus medications anymore. The fact that the back teeth are out of the interferences, he's not bruxing anymore, he's not clenching so much anymore, and basically he stopped intruding his teeth into sinuses, and he's just stopped having sinus problems, stopped taking the medication, and just generally speaking feels a lot much better. Plus his tinnitus reduced by about 70%. We don't necessarily understand why that happens, but we know it does happen in some patients. This young lady is a dental hygienist. She wore her teeth. She had headaches. She was grinding a lot. Her husband's a dentist. He tried to do some ortho on her. Ortho did not correct the problem. Actually, he stopped the ortho before the end because she was having too much headaches during the ortho. So she's class 2. She has somewhat of a retrognathic mandible, and she had a lot of interferences in the back. The bite was off, and she was just clenching and grinding away like crazy. She did start wearing a night guard. They made a night guard for her. It was a little bit better, but it wasn't completely adjusted nor fully adjusted, so it wasn't completely getting rid of her symptoms. And her husband, the dentist, was a man that did a doctor that did a lot of crown and bridge, and he did full mouth rehabs. He did his wife's parents and his wife's brother, but he did not want to do his wife. So he called me up, said, Alain, we're old friends. Would you please do my wife's rehab? So we started with a fully adjusted night guard, like I talk about them. And again, seated condyles, seated canines on the night guard, no posterior contact or very, very shallow posterior contact. And you get that canine guidance and the incisal guidance without any posterior interferences. And in case I don't know who's aware of this or who isn't, but there was an article published in 1983 in the Journal of Prosthetic Dentistry where they described the physiologic relationship between the posterior teeth and the elevator muscles, masseter, temporalis, and medial pterygoid. Now, if you put your hands on your masseters and on your temporalis, and actually better if you take your glasses off if you have them. So you put your hands here and you clench your posterior teeth, you're going to feel the contraction in the muscle. So you're going to feel the bulging of the masseters and the temporalis muscles. And for those of you who can, get to the edge-to-edge position and try to make those muscles bulge as much. And you will see it is an absolute impossibility. The temporalis won't move at all when you're in the edge-to-edge position, and the masseter does bulge a little bit, but about half of what it would when the posteriors, or what it does when the posteriors touch. So it was learned from that that there's a physiological reflex between the posteriors and the capacity of the elevator muscles to contract. So if you have no contact of the posteriors, you actually cannot solicit your elevator muscles to 100% or solicit 100% of the muscle fibers. So actually you only have 1/3 to 1/4 of the possible applied force. So if you're on the incisal edge or on the canine, you can't contract your muscles to 100%. You can only contract them to 25 to 33%. As soon as you have one posterior contact, and it's an all or nothing thing, there's no tamper zone, so no tampon zone. So you actually have an all or nothing effect. So as soon as one of the posteriors touches, you have full capacity to contract those muscles. Now, what that means is that you better get perfect anterior guidance, because if you don't get perfect anterior guidance, you have any posteriors touching, you're actually going to get higher muscle activity and more risk for the teeth, more risk for the periodontium, more risk to the muscles, and more risk to the joint, more risk to the whole system and its elements. So this lady's bite was off, and she had been grinding. The contacts and the interferences on the back teeth were stimulating the muscles. And as that happened, she was breaking her mouth down, and eventually wanted a rehab, but she only wanted her upper teeth rehab. She said, my lower teeth, I'm fine with them. Please do the upper teeth. So again, it's the same principle. We just redid the bite to the same bite I do the night guards to. So for me, a rehab or a night guard is actually the same thing. It's just a perfect bite. The goal is to redistribute the forces, get the molars out of the way from seated condyle to seated canine, and get them out of the way going sideways. And it's always the same. So in 99% of cases, there are exceptions, but no time for this tonight. So most cases, whether you're doing a rehab, whether you're doing an occlusal equilibration, whether you're doing a splint, it's the same principles that apply because they're physiological principles. And again, you can see pure canine guidance discluding everything, pure canine guidance discluding absolutely everything, pure incisal guidance going forward discluding absolutely everything. And this is the before and this is the after, of course, the zirconium, by the way. And she's out of her headaches. She'd been in headaches for the past 25 years. I did the night guard for her before we did the rehab, just to make sure that a perfect bite would be helpful for her. Doing the night guard, the headaches did go away, and after the rehab, the headaches have been gone for the past 3 or 4 years that we've done this rehab. Now, this patient, again, the jaw is skewed. It's not, both ramuses are not the same length. She consulted for intense pain, muscle fatigue in both joints, muscle fatigue and pain in both joints, had a hard time opening her mouth, had a hard time chewing and talking, clenched day and night, occasionally had clicking in her joint. She had orthodontic treatment that was finished in 2014. I saw her, was it 2 or 3 years ago? During her orthodontic treatment, surgery was proposed, but because she had no symptoms back then, she did not accept to go through the surgery to complete the case. So this is the first images of 2019, and October 2009, the joints seem good. The condyles look good. Now, June 2014, again, the joints look pretty good. Now, this is 2010 pre-op for the first orthodontic treatment, or for the orthodontic treatment she had then. So that was her bite, a little bit, a nice overjet, and class 2 and everything. This was June 2014, just a little bit post-op. Bite was much better. Orthodontic work was done well. And then in 2019, the bite opened up in the front again. And in 2021, she had even more degradation. The whole bite retruded and shifted to her left side. Now, on the MRI in 2021, you can see that the right joint is intact in the sense that the disc is somewhat out of place. It's a little bit forward, but the condyle has a nice outer layer, a nice cortical layer, nice and thick. This is beautiful. But if you look at the left joint, there is absolutely no cortical layer left. So this is the outline of the condyle all the way here. This is the angle of the mandible. This is the 7th tooth. And so this whole thing is a condyle, but there is, like on here, you can see the nice black surface, nice thick black surface, and here there is none. This condyle has lost its disc and is now in severe osteoarthritis. And that is why the bite shifted to that left side. And that is why now she's having pain on that left side. So the disc being completely out She had bone-to-bone contact. That started wearing down a little bit. Bite shifted to that left side, increasing the pressure on the teeth on that side, increasing the pressure on the joint on that side. And the sad part of the story is that the more the joint degrades, the more you're going to have pressure on a degrading joint. So as the joint degrades, the bite skews to the side of degradation. When this degrades even more, the bite skews even more, then you get even more pressure on that side, and then you get even more pressure on the degrading joint. So what you think is going to happen? It just keeps on degrading and keeps on getting worse and worse. And if you come back, this is what happens within just a 2-year period. So we eventually did a night guard for her, and we're now in the process of getting that condyle to try and heal. Eventually it will or will not heal. If it heals perfect, then we will have her go through orthodontics again, reset the bite, do a bite adjustment, keep her on a night guard for life, check her bite for life to make sure that the bite is fully adjusted and stays fully adjusted with equal pressures on both sides, canine guidance, and the whole shebang. If her joint doesn't stop degrading, then we go to prosthetics. So we replace the joint with a prosthesis. That is becoming more and more popular, more and more common. And well, we may talk a little bit more about that in a minute because we have a case of that. But a few years ago, we were trying to avoid making a prosthetic joint, and today the surgeons today are just doing them on a regular basis because it's an end-stage surgery, and they don't have to go back and back and back again into that joint. They just replace it with a prosthesis, and people are typically quite well. Okay, this is a dental secretary. So she's a secretary in the dental office. Mandible is a little bit shorter on her left side, a little bit longer on her right side. She is short and retrognathic, and she had poorly broken down teeth, severely broken down teeth, poor teeth, and she wanted a rehab. So basically, in 2013, 2014, she had a complete rehab. She had a hard time opening. They did the rehab in any case. Eventually, in 2015, she started having pain and had arthroscopy and cortisone injections in her left joint. She had bite splints that were made. She broke them. Now, the story on breaking bite splints or night guards is typically quite simple. If the back teeth are touching the guard, the patient can actually clench a lot harder than if the back teeth are not touching the guard because the muscles are turned on by the posterior tooth contact. So it has been measured. This has been published. If you take a contact on the second molar and a contact on the first canine, so if you have a contact only on the second molar or a contact only on the canine, you actually have 10 times more power on the molar and 10 times less power on the canine because of the lever effect and because of the muscles being shut off. So the canine being 1.8 times further from the joint than the molar, you have, if you square 1.8, that's 3.2 times less force applied. And if you count that muscles are 2/3 shut off, that's another 3 times less power. So you have basically a 9 to 10 decrease in power force if you apply just the canine versus that second molar. So if your night guard has contact in the back, patient can typically break it if they clench. If your night guard has contact more in the front, and we teach in the course how to do that and how to avoid extrusion and all of that. I've had all these questions. And so we totally take care of all of that. And in the course, we go through all of that in all the detail, of course. So if you make the contacts a little bit stronger in the front, less strong in the back, patients typically don't bite into the guard, reduces the muscle effort. much calmer patient, and it helps a lot more. And they just typically don't break them unless they drop them or their dog eats them, and that's a classical one at home. So she had orthodontic treatment. She had some injections into the joint. She broke her bite splints, and she came to us with contacts on the 2 second molars on her left side only. And this is basically a year and a half after her full mouth rehab. So in March of 2018, when she came to us, her right joint had a nice cortical layer. The condyle looked good, even though it's short. You know, it's a little bit under the coronoid process. But on this side, you got a little ditch in it. So this condyle already has some osteoarthritic damage. I mean, if you see this on the panoramic image, it's already bad. It may not be, it may not be a condyle that needs prosthetic replacement yet, but this is bad. This is bad news happening or starting to happen. Now, if we go to the next panoramic image, which is December of 2018, we are 9 months down the line. Look at the difference between this and that. Now, you see the difference in the condyle. Let's look at that again. Condyle starting to break down, 9 months later, totally broken down. Now let's look at the bite. If you don't want to believe me for the condyle, let's look at the bites. Bite space on the panoramic image is the same here and there in 2018, or at least close to the same in March. This is December. Look at how the bite has totally shifted to the left side because of the degradation of the condyle. And this condyle did not stay in the fossa. This is a totally displaced condyle with the protrusion that we do in the panoramic image. So this condyle didn't stay seated, and this cheated an image. That condyle is way out under the eminence like it's supposed to be. So this is true condylar degeneration and bite shift caused by the condylar degeneration. And this, my friends, happens a lot more than we thought it did. This happens on a regular basis. I see these, maybe not with a full mouth rehab, but I see such a degradation in condyles at least once a week in my patients. I could actually, the lecture tonight is 12 cases. I do lectures with 40 and 50 cases, and I could make a new lecture every other month. It is absolutely saddening to see how many people. We have 2,000 references a year at our clinic. We're 2 dentists full-time. We see 2,000 new patients a year. And of course, all we do is bite issues and splints and occlusal equilibration and a few rehabs once in a while when the dentists don't want to do them. They're afraid of doing them because of the heavy clenching, so we do them for them. But 95, 96% of what we do is bite adjustments and splints and diagnosis of what's going on, and eventually referring to the surgeon. Like in this case, there was nothing to do. This was degrading. We tried to adjust her bite. We tried the splint. Nothing worked. This just kept on going and going. Patient is a smoker. And again, I don't know the status of smoking elsewhere in the world, but in North America, it is now very low. We're down to, I think, close to 20% of the population only that smokes, but she's a smoker. Smoking kills the microcirculation, and that's what's the microcirculation is what's going on within that condyle. And smokers are worse off with condylar degeneration than others. So this is the skewing of her bite to her left side. And, well, basically, oh, wait a minute. Oh, I thought we had it. We have a picture of her. Sorry, we didn't put that in tonight. We have a picture of her prosthetic joint, but we have one. I promise we have one further. So basically, we had tried to adjust her bite, and it just wasn't working. So we eventually sent her to the surgeon. After 6 months of treatment with us, nothing was working, and nothing we tried was working. So basically, we sent her to the surgeon. Surgeon did a prosthetic joint, but she's still in pain. Again, most probably because she's a smoker and the healing is not happening like it's supposed to. This patient, okay, this patient, young female, 43-year-old woman, walked into the office during her ortho treatment. Towards the end, there was like 3-4 months left of Invisalign to do. So near the end of the treatment, and started having pain. So she pain on her in her left joint, and as time went by, the pain was getting worse and worse. So in the end, the orthodontist sent her to me, and we did an MRI, and there was no sign of osteoarthritic damage on the panoramic image before the treatment. So again, this orthodontist has followed my courses. They know about joint pathology, and they took a panoramic image before, and there was no osteoarthritic damage visible on the panoramic image before the ortho treatment. And so you have that here. Let me just push that up. Yeah, you have that here. This is pre-ortho, so it looks pretty good. Okay, why did that stop working? Okay, gotcha. Now, this is the MRI when she walked in 2022. So if you look at the right joint, you have a good cortex of the condyle, closed mouth, condyle is within the fossa, the disc is way out here. This is open mouth, so the fossa is here, the condyle is down under the eminence, the disc is pushed out. So this is a non-reducing disc. It does have bone-to-bone contact, but the condyle is intact. The cortical layer of the condyle is absolutely beautiful. However, if you look at the left joint, so this is closed mouth. So this is the condyle without a cortical layer. Condyle is here. There is no cortical layer here. Nothing compared to the other side. The disc is fully out. And on the open mouth view, you have the disc being totally pushed out, and you have the condyle under the eminence, and it rubs. Actually, this is a little bit of bone sticking out here. So this is the shape of the condyle, and there's bone-to-bone contact here, and total erosion of the surface. So this is osteoarthritic damage of that condyle. So was her pain strictly from stress? Tell me. So is this a case that you need to send to the psychologist? Is this a case that you need to send to the physiotherapist? Or is this a case of joint pathology where you have to understand what's going on and you should actually quickly make a bite splint to take some pressure off that joint? And that's an orthopedic principle. If you go look at orthopedic texts, they will tell you that in any case of, if you take the knee or the hip and they have osteoarthritic damage, the patient has pain, first thing to do is to reduce the load off the joint. It is an orthopedic principle. It just makes sense. And it's the same in the temporomandibular joint. If this is happening, that bite is skewing slowly towards that side, bite being shifted towards that side, bite gets heavier on that side, force on the condyle gets heavier, and you're just basically creating degradation of that joint and accelerated degradation of that joint and perpetuation of that degradation. So we made an equilibrated splint for her, and then a second MRI was done a year later. And here we can compare 2022. This is enlarged so you can see it well. The surface of the condyle is not there. And 1 year later, 2023, surface of the condyle is totally reformed. And you even have the retrodiscal tissue behind the disc. This is the disc out here. This black line is thickening of the retrodiscal tissue. So you had adaptation of the bone, and you also had a little bit of adaptation of that tissue there. So by reducing the load, you permitted the body to actually adapt. And I mean, I'm showing this case because it's fun. It doesn't work all the time. Some people, like the patient right before, this did not happen in that patient, and that other patient had to have a joint replacement, but it worked in this one. And there is a relatively high percentage of patients for which this does function, because reducing the load off the joint actually gives the body a chance to adapt. I expressly avoid the word heal. I say adapt, because this is not, well, it's partial healing, but we call it adaptation and not total healing because you're not growing the condyle back. Now, this case, you can right off the bat, you can appreciate that this patient has no space here between the condyles and the eminence or the fossa. So this patient lost his discs. I just saw this patient a couple of weeks ago. This is a totally new case. And what's sad is this patient is only 42 years old, but look at all the periodontal damage. So different patients react in different ways to the same stimuli. So this patient got the disc displaced at a younger age, whatever age, I don't know, but the discs were displaced younger. Discs are non-reducible because even in the panoramic position, which is slight protrusion, there's bone-to-bone contact, means there's no disc interposed, so there's no reduction, so discs are just being pushed out. All the bite is on the posterior teeth. This patient actually came in saying, Doc, and he wasn't sent to me for periodontal disease. He was sent to me because the bite was changing. He went from a closed bite to an open bite and only pressure on his molars. Now, masticatory system is a system. It has teeth, a periodontium, muscles, and joints. All sorts of other things, but that's the basic mechanical parts. Now, having excessive force in the system will lead to breakdown of the weaker part of the system or weaker parts of the system. And in this case, the bones are weak. Like some people have very strong bones. They grind, they'll wear down their teeth. Some people have very weak bones and they have strong teeth, or they just have weak bones. And if they grind on weak bones, what happens is that the teeth become loose. And this is what's happening to this gentleman. He doesn't even have, if you look, there's no tartar. I mean, this is not infectious periodontal disease. This is not caused by tartar. This is caused by clenching and grinding. I mean, he has developed pockets and he does have some infection, but this is not from tartar accumulation. This guy's clean. This guy just ground his teeth out of the bone. Most teeth are slightly, yeah, he has a couple of teeth that are slightly mobile, not too much mobility, but he's lost a couple of teeth already, and he came to me so he'd stop losing his teeth. I mean, okay, a couple of those I'm not sure of. I mean, this one I'm not sure of. This one I'm not sure of. The rest of them, yeah, well, hopefully you can do something. But what are we going to do? He has a total open bite in the front. And can you really try and do orthodontics on this type of case? If I was an orthodontist, I'd be weary of touching this case. I'm not an orthodontist. I can't speak for them, but I've seen cases where the orthodontist did not want to touch these cases. And looking at the joints, if you were an orthodontist, would you want to touch this case? Do you actually think that the bite would be stable after, or would you kind of suspect that these are degrading, and as time went by, even if you got those teeth close together, as the joints kept on degrading, you would actually have relapse and reopening of the bite, and the whole problem would just start right over again. So we plan on doing a night guard. We're going to take some pressure off the joints, take some pressure off those back teeth, distribute the forces as well as we can, and we are just going to hope for the best. We cannot make a promise to these patients. We're never sure of what's going to happen. And that's one thing. In bite issues, we're not dealing with a tooth and decay that you just grind away and fill. We're not dealing with a crown, which is a process we've been dealing with for years and years and years and decades, and we know the process, we know the success rates. Here, I hold statistics. We'll see them a little bit later on towards the end of the lecture. We'll see my statistics of success at reducing muscle tension and headaches and neck pain and joint pain. And we have high success since I've been using the night guard we're going to talk about, or we have been talking about it. But we can never promise results to any specific patient. We have to be very careful of that. Doctors never promise they're going to take away your diabetes, or never promise they're going to take away your Alzheimer's, your Parkinson's, or or your um, your high blood pressure, or whatever medical disease. Doctors have a tendency to understand that they're managing disease. Dentists have a tendency to think we fix things. We actually manage things in a very good way, but a crown tooth is not a natural tooth. It's rebuilt. It's not new. It's rebuilt. So when we talk about joint problems and bite problems and occlusal wear and all of that, we're actually managing problems. We're not curing patients. We're managing patients. We're helping them with their problem. And that has to be understood. And you have to understand what's going on within the system if you want to explain to a patient why they need their night guard. Now, I hope that the people that are attending this lecture were not aware of what I'm talking about tonight, because I hope you're learning something new and I hope you're seeing something new. And if you are, I hope you're learning from it. And I hope you'll be looking at your panoramic images a little bit differently and looking at the bites a little bit differently and understanding a little bit more what's going on in your patient's mouths, to be able to talk to them, tell them, okay, well, listen, your bite's skewed, you're off, you have more pressure on one side than the other. Use the marking paper, show them, and eventually help them understand why a night guard is going to be effective for them. It's not just something you have to wear between your teeth to protect them. It's a lot more than that. It's redistribute the forces so that you're not going to break down as much. I mean, let's give this little pearl right away. I was going to do this at the end. We're here now. This is a pearl to take away from this lecture. Most dentists, when they see wear and tear in the patient's mouth, tell them, well, I think you've been grinding your teeth, you should get a night guard. What is the typical patient answer to that? It's very simple. It's, I don't grind. I sleep with my mouth open. My spouse doesn't tell me I grind. I snore, so my mouth is open. I never clench my teeth. I don't do that. I don't wake up with tension in my jaw in the morning. Those are the typical answers you get, and you get, and you got, and you got, and you got again every time you said that to patients. You've been grinding your teeth. And that really closes the door on any further discussion. They don't want to go there. And I don't know why. I don't know why it works that way, but they're sort of refractory to understanding that. So they just shut the door, end the conversation, and you never get to getting them a night guard and the protection they actually need. So one day I turned that around. For some odd reason, I had an idea, it just came on to me, and I said, well, instead of telling them they ground their teeth, I looked at the patient, I said, I was actually sick and tired, and I was actually desperate that day. And I just looked at this nth patient of the day, and I said, how'd you get your teeth like that? How'd you get your teeth so degraded like that? And the patient was stunned and looked at me. He said, well, I don't know. Do I grind my teeth? Well, I said, I don't know. I don't sleep with you. But I can sure see that you're working hard because you're tearing those teeth away. And that opened the conversation. So instead of telling a patient that they grind their teeth, ask them how they broke their teeth so much and shut up. Let them give you the answer. And 99% of the time, they'll give you the right answer. Or they'll give you an answer that they will believe because they created the answer. And it's most of the time better than the answer you would have given. And it works like magic. Anyways, hope you get to use that, hope you try it, and hope it works for you. So, yeah, this patient had ortho when he was younger. His occlusion changed since he entered the ortho. He eventually developed the anterior open bite. He's undergoing periodontal treatment because of all the recessions he has and all the bone loss. And the contacts are even stronger on the right side. He feels pressure on his jaw when he wakes, has temporal headaches, cracking that stopped and started again, so that joint's degrading. And basically, he's not doing very well. So we're going to make the night guard for him and try to stabilize things. And again, as I said, hope for the best. We're also going to do an MRI of his joints, and we may consider an orthodontic treatment if any orthodontist wants to start working on those teeth, and possibly he needed to have orthognathic surgery as well to reposition or reset the jaw. But we have to be sure those joints are stable before orthognathic surgery. Have to make sure their condyles are nice and solid before that happens. This patient, a different type of case. I tried to put in a lot of different types of cases, meaning a lot of different types of things that can happen from a degrading joint or a poor bite. This patient had some periodontal disease, but actually this is excessive force on the bicuspids. This long span bridge was made, and to prevent any force from happening on this weak area, the dentist adjusted this with all the pressure on the back teeth. Now, all the occlusion was on these little bicuspids. So this one actually just eventually fell out of place, and the patient sought out for implants. And so this tooth was extracted. 2 implants were put in here. This one was kept because it was good. 2 implants were put in here. The dentist putting in the implants was not the dentist that put in the crowns on those implants. And I know very well the dentist that put in these implants. She's very good. Well, anyway, I can tell you she's good, but she is. She takes her time, does things right, make sure the osseointegration is good, takes her x-rays, make sure that all that is perfect, integration is perfect all around. Took another x-ray after the crowns were put in, everything is perfect, but she did not do the crowns on these implants. The restorative dentist that did this on the top put the crowns. And again, wanting to protect this bridge and this weak part of the bridge in front, put all of the pressure on the back on the implants. Now, I know some people say that the occlusion on the implant doesn't have any importance, and some people say it's all important. But in this case, now this is October 2014, and this is April 2016, basically a year and a half later, and look at all the damage around this implant and all the damage around these 2 implants. So a year and a half later, 3 of these implants had to be removed, and this was a lawsuit case. All the bite, all the pressure was here in the back, no guidance in the front, and this turns the muscles on, and because the muscles are turned on, you get more clenching, you get all the pressure there, and this was just destroyed. Now, if this patient had been warned of that and had worn a bite splint, well, maybe this wouldn't have happened. And if instead of implants down here, they cut the bridge, put implants up here, given a proper bite, given occlusal guidance, given incisal guidance and canine guidance, well, and an occlusal guard, well, possibly this would have been saved, and this patient could have lived with their implants happily ever after, like most of the patients we see. Now, this is a sad case in itself, but from our point of view, this is even sadder because this patient is a young dentist. And the sad part is that this dentist, as a child, went through all sorts of orthodontic procedures, eventually had orthodontics a second and third time, had maxillofacial surgery, orthognathic surgery, and was in absolute excruciating pain after that, and did not understand what was going on, why there was relapses. That dentist had no clue of what was going on in her mouth and why she was suffering so much. And she was told it's stress, it's anxiety, it's in your head, and blah, blah, blah. Okay. Now, I'm not saying that that doesn't exist. Now, let's be careful with what we're saying. I'm not saying that that does not exist. That does exist. But have a look to see if there's pathology too. Stress exists. It exacerbates the problems. But there are occlusal discrepancies. There are joint issues in most of these pain patients, at least the ones I get to see. Now, there are patients that I treat occlusally. I get them good occlusally, get their bite right, and they're still in pain because they're overly stressed. but this is a minor population compared to the total population. It's less than 5% of the cases we treat that we don't get them seriously out of pain. We don't get rid of all the pain in everyone, but we get rid of 80% of the pain in 80% of the people. And there's like a small percentage of reduction of pain in a small percentage of people and no reduction of pain in about 5% of people. And those people are the ones that are highly stressed and where the pain comes from the stress and other sources. But don't get into the thinking that all of these patients are stressed and there's nothing I can do and the bite has nothing to do with it. All of that is not true. And I've been proving that for the past 30 years. Now, there are the two things that concur to create these pain problems. So you have to have enough bite and you have to have some stress. But the stress is not the main issue in most cases. It's a secondary issue in most cases, and it's a main issue in a percentage of cases. So you have to make sure you understand all the everything that's going on. Now, so this dentist was what, 8 or 9 years old on this picture, and this is her original bite. This is the way her teeth are set. And what I like you to look at here is the way the teeth are set. This is how bad the joints were affected. That means that she was a mouth breather, yes. She did have tongue posture problems, yes. She did have swallowing problems, yes. But with the poor size of the mandible, her tongue had no space to go. And the poor size of the mandible comes from the fact that she had her disc displaced when she was very young. Now, oh, okay. This was after phase 1 of ortho in March 2004. So the orthodontist for phase 1 did a pretty good job. I mean, this looks good. The teeth are closed. This is edge to edge. This looks closed. It looks nice. Panoramic images shows us nothing really wrong. Everything looks okay. It looks normal. And this is after phase 2. Now, look at the retrognathic chin on her. These teeth had to be severely extruded to come in meet. If you look at the maxilla, it is totally, the whole anterior section of the maxilla is totally twisted upward. I mean, that tongue is still in there. It's up there because it has no space down in the down low. So it's up there, up in front, because there's no space for it within the mandible. And this is a precursor to getting that bite to eventually open up. And this only happens in a short mandible, and short mandibles only happen when 99% of the time happens when the discs are displaced and there's some sort of condylar subgrowth or eventually degradation. So the condyles on this panoramic image are getting smaller. Like these are small, much smaller than the previous panoramic image. Let's go see. A little bit larger here, a little bit smaller here. And then this is before the second ortho treatment because she was developing that open bite. The teeth were not touching anymore as her mandible, as her discs were pushed more forward. The condyles were degrading and getting smaller. Mandible retruded even more. And this time they did orthognathic surgery and ortho. And wow, look at this. This is beautiful. This is a beautiful job. Okay, and the bite's right. And it looks great. But this is being made up. This is not nature. You have to understand that her nature is retrognathic with poor joints. This does not correct the poor joints. This is cosmetic. It is not something that addresses the joint issue. Yes, the bite's better. Yes, it does take a little bit of pressure off the joint, but it doesn't heal the joint. And if the bite isn't totally and perfectly addressed, then you still have pressure in the joint. And the joint was not addressed in this case. And the patient just had severe breakdown. There is no condyle left. This is basically a little bit of neck of condyle left. A little bit of condyle left here. Absolutely nothing left here. And this is a couple of years after the orthognathic surgery. And she's in severe pain. And the bite shifted to the left again. And this is degrading again. And this is after her third orthodontic treatment. And she is a 28-year-old dentist when she comes into me in this state. And she is not understanding what's going on in her mouth. She has no clue that her condyles have been degrading for the past 10 years. 10, 15 years, 20 years. So we didn't, this was just pre-COVID, 2000, this was the fall of 2019. And she came to me as a patient, then she came to me to take the splint course, made herself a perfectly adjusted splint, and I didn't see her for another 3-4 years. And then last year I saw her again, and she'd been wearing day in, day out that night guard, and she said, Alain, my joint has stabilized. For some odd reason, it stopped degrading. The bites had stopped changing. She was skewed to the left. Sorry, she was skewed to her left side. The contacts were very strong and high on her left side, a long slide, a long interference. And but she was out of pain because she was on her night guard. And she came to the second course, which is principles of occlusion and how to do an equilibration, how to rehab. And she said, would you please equilibrate my mouth? And we did it as a demo. And came in the next morning telling me I've not been so comfortable ever in my life, because the canines were touching. She was as comfortable tooth against tooth as she was tooth against night guard, because basically they were adjusted in exactly the same way. All right. And these are the joints on the MRI. So this is the right joint. Again, this is the condyle with the ditch in it, and this is open mouth, and the disc is way in front, bone-to-bone contact. And on this side, you can see there's almost no condyle left, totally osteoarthritic, and with the disc totally pushed in front. So these are non-reducing joints on both sides. Both sides have osteoarthritic damage, but the left side is just even worse. All right. This girl came into us. This is after orthognathic surgery to correct an open bite. And so that's how she came to me. Orthognathic surgery was done only on the lower to correct her open bite, but this was her bite when she came into me. This is after orthodontic and orthognathic correction of her open bite. A couple of years down the line, total relapse. Guess because of what? Joint degradation. The issue had not been addressed before the surgery. Joints were fragile. Surgery was done without consideration for the joint. Total relapse, all in the condyles. So and again, right joint, non-reducing disc is out. However, the surface of the condyle here is not too bad on the right side. Left side has no surface left. This is severe osteoarthritic damage. So we had her on a night guard for a year, calmed the damage down, had the condyle totally stop degrading, then sent her for orthodontic treatment with a combined Le Fort and again bilateral osteotomy on the bottom. And now her bite has been perfected and closed, and she has been good since 2019. So it's been about 2020. So this has been 4 years now. And because we stabilized the joints before, we made sure that bone was good, made sure the bite was perfect after, made a night guard for her, kept all the pressure off that joint that is not protected by a disc anymore. It's bone to bone. But if you keep the pressure off of it, day in, day out, so with the night guard and a fully equilibrated bite, she has the least possible amount of pressure, and she's just going to be better. And she has been stable for 4 years, no relapse, no degradation. This case, look at her chin. This is 3 years after orthognathic surgery. So again, this is a total relapse of orthognathic surgery. bite retrusion because the condyles were melting away. Condyles had not been addressed before the surgery. And yeah, this is 2014. This is the progression. This is 216 November and December. So she's severely degrading as we go along. We had her, this is the original orthodontic surgery. We had her wear a night guard. And in 1 year, you can see the difference in the condyles. So if you look at the, which is right, which is left, sorry, forgot to write it down, but it doesn't really matter because this is one side without a cortical layer. This is the condyle. This is 1 year later with a nice cortical layer starting to form around the condyle. This is one of the cases I published in 2019. This is cortical layer that is very thinned out, severe osteoarthritic damage, and this is the cortical layer being totally reformed, again, just a year later, but again, this is in a young patient with a lot of healing power. As you grow older, you're losing the cells in the condyle to grow or to grow a new surface. So the older you get, the harder this is to achieve, but it's pretty achievable pretty often in young patients. Doesn't always work out, but at least you need to try this before you go to replacing the joints with prostheses. This is 2020, so her bite has been corrected with orthodontics only. This was done with Invisalign. I don't know how the orthodontists do that, but correcting that open bite is a miracle in my eyes. So they corrected it pretty well. She still wears an eye guard. And these are the joints in 2021. So we are 5 or 6 years down the line from the last MRI, and the cortical layers on the condyles are absolutely beautiful. They have not degraded in the past 5, 6, 7 years, and she's just probably out of danger in most cases. In this case, she's probably out of danger for a long time because the occlusal factors are keeping the pressure off the joint. So we're giving her a chance to adapt and stay adapted. We're not controlling all the circumstances. Typically, these females, if they become pregnant or at menopause, they may see reintroduction of osteoarthritic damage happening. It's because of the hormones. The whole process is not totally understood, but we know that major hormonal changes, degradation keeps on going or can restart. So we monitor these patients, and they're all advised of that. Last case, this is a 19-year-old that we saw when she was actually 13 the first time. Sorry, let's go through that. This is her bite as it is when she came to us recently. That was like 2 years ago. This was in her younger years, the panoramic image. This is older. She had phase 1 orthodontics. She had a bionator type of appliance, mandibular advancement appliance when she was young, and that skewed the jaw to her right side because the disc was non-reducing on this side, was reducing on this side. So as the mandible was advanced, on the left side, the condyle came in underneath the disc, and that stimulated growth. But on her right side, the disc was totally in front of the condyle, and this is at age 11, 10 or 11. Disc was totally in front of the condyle, and as the dentist, the pediatric dentist, brought the mandible forward, the disc was just being pushed forward, the condyle was rubbing against the posterior slope of the eminence, and basically it just kept on degrading instead of growing. So as the left side grew and the right side degraded or didn't grow, the mandible skewed to the right side, and she called me up in panic, said, "This is the first time this ever happens to me with a mandibular advancement appliance. Please tell me what's going on." So we MRI'd her joints, and here the left side condyle, this is neocondyle, this is growing. The disc is relatively in place. It is a bit displaced, but it's still interposed between the condyle and the fossa. This is the left side. And on the right side, there is no growth, and this is a flattened condyle due to osteoarthritic damage and no growth, and the disc is totally out here, and it is non-reducing. So there's no protection. And this was at age 11 or 12-ish or something like that. So we do have osteoarthritic damage even that young. And this is what this whole lecture is about. In young patients, we have displaced discs in a majority of these young patients. Their bites are off because of it. Different types of forces apply. The bites are off. You will have a different series of effects going on in the mouth. The joints can be affected, the muscles can be affected, the teeth can be affected, the periodontium can be affected. Night guards should be used in all the patients, or should be at least suggested. Again, people ask me, do you treat everyone? No, I only treat people that want to be treated. Patient is refractory to listening to you. I mean, you've done your job. Your job is to advise them of the problems and tell them the options of solution. Night guard should be proposed to all the patients that have degradation in their mouth from excessive forces, and it should be written in the chart that if they don't want to have it, that the consequences, the possible consequences of non-treatment were explained to them. All right, so basically this is just the blah, blah, blah to go to the end of this case. Now, have a few minutes left. Let's go through the splint. This is bite splint delivery. So this is how we adjust the splint. So watch this closely. This is how I adjust all my night guards. Now, in the course, we'll discuss hard, soft, upper, lower, and all the things you need to know. But tonight, I'm going to show you how they are adjusted. This is a lower splint. We do uppers, we do lowers, depending on the cases, but this is how they're all adjusted. So basically the splint, this comes from the lab. The splint was tried in, it fit well, it seated well, did not need any work inside to have it seat. So that was good. And now we're going to have the patient close and retrude. They protrude and then retrude as far as they can and clench. And you check to see if there's any contact or if that paper, this is AccuFilm, so it's a 20 micron paper. We have to check and see if there's any excessive contact in the back. So as this patient retrudes, there you have that paper catching, and this is going to mark the night guard. So you have excessive contact there. We're going to check the other side. And again, it's the same. We have the patient protrude and retrude, retrude and clench. And then we check for any contact or excessive contact in the back. Symptomatic patients are adjusted to no contact in the back, but no contact only to the tolerance of that paper barely sliding through. So I don't want extrusion. So I will adjust the night guard to the tolerance of only a 20 micron thin paper barely sliding through. So we will adjust that because that was high, that was a heavy contact, just gentle adjustment, and we'll check it again. And again, every time I do any adjustment, I recheck. Molars, bicuspids. I recheck it all around every time I do any adjustment because you never know what a minute change can have as a consequence on other spots or other occlusal contacts. So again, retrude, try that. That slid through very, very well. So you feel a light resistance. There's a light resistance. You feel that paper scratching between the tooth and the splint. So there's no big space there. It's barely the paper sliding through with a little bit of that, a little bit of gentle tugging, not retention, but we just feel it scratching a little bit. And of course, in the course, we tell you how to take the bite to get to that result. And it's just so simple to make these perfect night guards that are absolutely comfortable and with an incredible level of effectiveness. We'll go through that in a couple of minutes. Once this video is done, we'll go through the success rates of this type of night guard compared to others. And you know that night guards I mean, the American Dental Association did a study where the patient's compliance to night guards is under 30%. With these, it's over 80. And actually in my practice, well, because patients are in pain probably, but we had a 95% compliance rate. So having the patient grind sideways, patient retrudes, clenches and grinds. And what do you have? You have that beautiful canine guidance popping up and nothing is happening in the back. So you got beautiful canine guidance, strict canine guidance on both sides, and in protrusion, what do you have? Beautiful incisal guidance. And this is just a case that worked absolutely beautifully. And this is total delivery time. This is all it should take. Once that splint is seated, then this is all the time that that should take. If you have proper impressions, proper bite records, your lab uses the bite, this should be the result. And that should be the only amount of time you have to invest in delivering a night guard. This is our bread and butter. We do this day in, day out, and been doing it for 15 years that way. Been doing it for 30 years, but 15 years that specific way. What's the difference between an ICO splint? By the way, the ICO splint is a registered trademark, so it has a name now. And basically, it eliminates absolutely all interferences in slide. And from a strictly mechanical standpoint, from a physiological standpoint, the ICO splint is designed to deliver the most optimal income. So it's the most physiological splint, it's the most mechanically effective splint. It's too long to explain all the effects of mechanical and physiological in this type of lecture, but it's explained totally and diligently in the course. And this has all been studied. Again, I've been doing this for over 30 years, have been everywhere around the planet, seeing what all other people's do. And basically, if I have time for a short story, I ended up eliminating those posterior contacts for, I used to do flat plane splint, equal contacts everywhere, like it's taught almost everywhere today. Those equal and make the posteriors equal to the anteriors, canine guidance and incisal guidance. But one day a patient came in telling me my splint was giving her headaches. So I checked my adjustment, made sure it was good, sent her home, blah, 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 3 times, comes back the third time again with headaches, says my splint's giving her headaches. And my splint, in my mind, have been reducing headaches for years. So I'm not understanding this patient. So I just take the burr, eventually eliminate those posterior contacts. And she comes back over a month later, and lo and behold, she is out of her headaches. And that's how I developed this system of having those posterior contacts slightly reduced, out of the way for symptomatic patients, in contact for non-symptomatic patients, but slightly out of the way for symptomatic patients. And that gets them a lot, that pushes the success rate with these patients to a much higher level. So the splint has been designed so that the teeth get the least possible amount of stress. The same for the periodontium and joints, mechanical stress and physiological stress, and also the muscles work the least, so they exert the least amount of pressure and force in the system. And it just translates into being the most possible effective splint that we have found up to now. There may someday be something better. This is just the best there is as of now. So anyways, again, I've been doing them for a long time, see 2,000 patients a year. We have like a very high level of success. So what type of splint should you use? I mean, we have to do splints. We have to do them for our patients. So you want them to use this from Amazon? Yeah, this is what people do nowadays because they're discouraged of the splints we're giving them that are not effective. So they resort to Amazon and they buy these things and they chew them out, they destroy them, and they destroy their muscles and their joints and their teeth using these. I give these lectures because I don't want my patients doing that. I don't want patients around the world getting this. And that's why I'm sharing this with you. And thank you to David and Michael for organizing all of these courses. Again, ADA says only 30% are worn. Most popular is a full coverage flat plane splint. And I just told you the story about that. That's what I used to do a long time ago, but then I adjusted it to the ICO splint level. And I just told you that story. And these are the statistics. Morning headaches, 90%, 95% of patients experience a decrease in headaches. Now that looks really good, but let's break that down. 50% of patients are out of their headaches. 33% have important reduction in headaches. 14% have a little bit of reduction, and about 10% have 5-6% actually have about no reduction. Muscle pain, which means masseter pain, basically. 93% have some reduction, but 41 have total reduction. 1/3 have important reduction, a little bit have a little bit of reduction, and very few, like 7%, have no reduction. Joint pain, 40% totally out of pain, 25% important reduction, 25% light reduction, and about 10% no reduction. Neck pain, the neck is influenced by the skewing of the jaw. The cervical alignment, that's been proven, by the way. I'm not just stating this. This has all been proven. So neck pain, we're less effective in the neck. Even though the main statistic says 93% of patients have decrease, it's only 22% that are out of pain. 15% have important decrease, 35% have a little bit of decrease, and 18% have no decrease. These are where the placebo effect come in. These can actually be no reduction, and they're just telling us because they like us, they have some little bit of reduction. So this is where the placebo effect comes in. Not here, because this is long-term, 1-year follow-up reduction. This may be placebo, this is not placebo. So the ICO splint, it's not perfect. It's just the best we have found up to now with 30 years of dedication to the whole thing. What is it? 10-minute impression, 10-minute delivery, the happiest patient, 90% plus, wear compliance. Sorry, compliance, that's a wrong word. Compliance rate versus the world average of 30%. We have to do night guards. Might as well do the better ones. So your patients trust you. They trust you to give you the best. Well, you can elevate your standards if you like. So the ICO splint method is what we have found to be the most effective up to now. The course exists. It's on startingwiththebasics.com. You will have a link. Michael and David will give you a link to go there. And follow the link they send you. And if you like to follow the course, well, we have just a lot more information. If you do follow the course, if you do like what we said tonight, and you are encouraged to do better, well, then do as good as you can until you know better. And when you know better, well, then just do better. So follow the link they'll give you, get the course, and I'll answer emails. We eventually do study clubs you'll be invited to ask the questions you may have. But the course was made really complete. We took the live courses. We noted all the questions people would ask in the live courses, and actually I answered all of them in the course. And we have theory and hands-on. It's all there. It is complete. So, David, I think I'm done. And there it is. So, microphone back to you, David. So thank you.
Thank you, Alain. I don't know how you talk for so long without taking a breath. Congratulations and well done on presenting a very thorough presentation on why everybody needs a splint. Alain, we're just finding that link now, and we'll put it in the chat. Can you, we've got some questions in the chat. Are you able to see those, or would you like me to read them to you while you...
Please read them, because right now I'm not seeing the chat.
Okay, can you
maybe I can get to it. No, it's not popping up for me.
That's okay.
No, sorry.
Okay, so the first question came from Ramisa, who said, cast your memory back to case 1. How did the splints help that lady in arresting her osteoarthritis, and what dimensions of night guards work in specific case? How did you instruct the lab?
Oh my God. Okay, that question is answered thoroughly in the course. It's too long to answer the instructions to the lab. There's like 3 pages of instructions. Once the lab knows how to do them, my prescription is now make the ICO splint, and they understand what that entails. Again, if you remember the delivery we did, the instructions are to get to that point. So we want a night guard that's going to be made from seated condyle position. So your bite has to be recorded with the condyle seated. I have to have a good set of impressions. We're strictly digital. We have been for a number of years, and it just works beautifully. If your lab uses your seated condyle splint. It will come back with minimal adjustments, and you have to make sure you get canine guidance and sizal guidance. Now, labs typically understand that. You just have to work back and forth a couple of times to get that done.
All
Again, the
right.
course is very explicit on how that's done. Now, how did that help that lady? Well, basically by reestablishing an equal bite on both sides with a little bit more pressure in the front, you're reducing the load off the condyle. And that's how that degradation stopped. You just reduce the load off the condyle by bringing the pressure up front instead of in the back. When you take the pressure off those teeth, off those posterior teeth, the muscles aren't able to clench. And because of the lever effect, I mean, if you have a nut cracker, you're breaking the nut back here, not up there. Up there, you're not able to break the nut because there's no force because of the lever effect, or the inverse of the lever effect. So bring it forward, shut the muscles off, get the contacts in the front, and you're just really, really taking a lot of load off those back teeth and off those joints. And that's how it works. The principle is very simple.
Excellent. Now, another question from Dr. Quan Lee, who said, can you please show him how to make the occlusal appliance to accommodate the joint? I know it's the cookie cutter, but please show me an example of appliance design. Well, I'm thinking he's probably going to take the course, right?
Yes, yes, yes. I apologize. I cannot do that tonight. It takes 2 days to show you how to do that, and that's the whole subject of the course. Again, this is a lecture presentation, and I'm seeing that you're interested, so I'm happy I succeeded in getting your saliva flowing, which is very good. Again, if you remind yourself of the video of the delivery, that is the goal to attain in all patients, either upper or lower. And again, in the course, we discussed the 7 criteria to decide if it's upper or lower. But once you decided which one, that is the goal to get to.
Those compliance rates that you talk about are just off the chart, Alain. And you know, if I was a practicing dentist, I'd be signing up for the course because you know, nobody likes to spend money on buying something that then ends up in a bathroom cabinet or in a bedside drawer because they hoped it would work, but they weren't able to tolerate it. And you and I know that appliance therapy is far more comfortable than a CPAP machine, which is another route that the amateur patient goes down thinking they need that instead of investigating all angles. So I recommend for every dentist to do the course so that they can make a very comfortable appliance that patients have no trouble wearing. I've seen people with CPAP machines on planes. I don't know how they can get them on, carry them onto a plane and then get them running on the plane, but they
How
do.
do you plug them in?
Yeah.
It doesn't work in a USB slot. That doesn't work. I haven't
Yeah.
seen it anyways. By
Yeah.
the way, David, I didn't talk about it, but you can't know the number of splints that I see patients come in with, and I don't even make a new splint. All I do is readjust the one they have. I think at least 1/3 of my splint patients are on their old splints. All I did was readjust it. I mean, it was well made. It was well seated on the teeth. It was not too tight or anything. It was just uncomfortable in the bite. And it's just that same splint. I just put those papers in, have them protrude and retrude and clench and clench and clench and grind all those posteriors away. Or sometimes you have to thicken it a bit in the front if it gets too thin in the back. But you just make it to that delivery video we did. And basically, the patients come in and say, this went from horrendous to saving my life,
Oh,
just
fantastic.
because that pressure is off. So at least 1/3 of the splints my patients have in their mouths are their own they came in with, and it costs them a lot less. So this is very cost effective for the patient. Knowing and understanding the principles and applying them is extremely cost effective for the patient. And you build a reputation by doing that. And you just get more and more referrals. I went from 15 years ago, 150 referrals a year to 2,000 this year.
That's sensational. Obviously, this is a proven approach that you've got that's working well for you. It's working for your students. So why
Been
wouldn't it
teaching
work
it for
better for-
15 years and they
Yeah.
all love it. In the
Yep.
province of Quebec, 50% of splints made are, we call them here Aubé splints. I call them the ICO splint because that's easier to pronounce for most people outside of Quebec. But 50% of all splints made here are now Aubé splints because they work. I mean, in here they're called the magical splints. I don't like that because they're not magical. And they don't cure everything, but they just work so often and so much more than all the others that they're called that way.
Dr. Kwan Lee's got an interesting question. Again, he's probably, I think, Kwan, you're going to have to buy the course. How do you find the stable position of the joint? Is it just by the patient's sense that they're in the right position? How does that
That's
work?
an excellent question. And now, okay, now we didn't talk about it because this was not the subject. But if you go to the website, you will find 3 courses. You will find the Splint course as the #1 course to do. You will find the occlusion principle course, which is the 2nd course to do. This teaches you the principles of occlusion, principles of rehab. It will teach you how to adjust the bite on the natural dentition and onto rehab. 3rd course is TMJ pathology, MRI reading, and all of that stuff. Now, that question is answered in detail in course 3. Basically, there's 3 aspects to the stability of a temporomandibular joint. Now, what dentists call stability is different from what physiotherapists call stability. So a physical therapist and a dentist call stability a different thing in a joint. So I won't explain what the physiotherapist understand, but what the dentist understand is this. If that condyle is not degrading, it is dimensionally stable. If there's effusion, if there's no effusion in the deep part of the fossa, and a lot of patients have effusion, inflammation and effusion, if there's no inflammation, that joint is stable. But if there is inflammation in the deep part of the fossa, you have a little bit of lake of liquid on which the condyle is resting. As the volume of that retrodiscal, as the volume of that synovial fluid changes, that condyle changes position, and that the patient will tell you, my bite's changing all the time. The other thing that happens is that those discs, sometimes they're secured in one position and sometimes they're not, they're wobbly, or sometimes, like especially in patients in their teens and early 20s, the discs are slowly progressing out. So they're going from a reducing disc to a non-reducing disc. And as that changes, the condyle changes position, the bite changes, and that is a situation where you don't want to do a bite adjustment because it's just changing from month to month. So a stable joint is a joint where the disc has stopped changing position, the condyle is not degrading, and there's no effusion to create instability of the seating of the joint. And how we find that? Simple, leaf gauge. Use the leaf gauge. Get the leaf gauge in there, you will find the stable position, but finding the stable position is different from doing the diagnostics of making sure the joint is stable. So the joint must be stable before you find the stable position. Luckily, most of your patients have stable joints. Most of them have stable joints. They don't have degradation to condyle. They don't have osteoarthritis going on. They don't have their discs in a state of continual displacement, and they don't have that much effusion. So 95% of your patients use a leaf gauge, get the condyle seated, boom, take your bite there, you're good.
Okay.
We have a video, of course. We have in the course, there's a video on how to do that. Now you
Excellent.
can learn on internet, but you can follow the course and do what you want, but make sure you do them well.
Now, Kwan's also asked a question that clenchers will clench anyway, whereas a night guard will protect a grinder but not a clencher. Is that
That's
true?
false.
That's
That's
false.
false.
Yeah.
That's very false.
Oh.
Now, statistically, in my practice for the past 30 years, there are clenchers that will clench whatever you do. Absolutely. Those exist. They're about 3 to 5% of the population. They do exist. But I've I should not use that word. That's not true. I've helped patients to get out of their clenching because the back teeth are not in the way anymore, and that turns the muscles off. And at least 80% of the patients I treat And I often start with the night guard, stabilize the system, calm it down, go to the bite adjustment after, do the occlusal equilibration after. Once that's done, 80% of patients don't need a night guard anymore. 20% do, 80% do not. I used to be a clencher. I used to have tinnitus. I used to have morning headaches. I used to have stiff neck. That has been gone for the past 27 years. I have not had a morning headache and not had a stiff neck in the past 27 years because my bite's adjusted. I have a night guard. I don't wear it except when I'm stressed out. If I'm going through a stressful period of life and there's 3, 4 days where I feel that first day I feel the clenching, I say, okay, I felt the clenching, resort to the night guard, use it for 3, 4 nights a week, 2 weeks, whatever's happening. And then we've just built a house 2 years ago. I wore it a lot the past 2 years. But
Every
okay,
house builder should get a night guard.
that's building a house post-COVID when there's no materials and the
No,
prices are
no,
skyrocketing and everything.
yeah.
So but now we're in this new house. Things have calmed down. I'm out of my night guard now. I just wear it occasionally. Like on a typical year, I wear it 15 to 20 nights. Now, that is true for the majority of patients. But yes, there is a subset of patients that will clench whatever you do, use a night guard. And again, the night guard I showed you is the go-to night guard for most cases. In the course, we go through 7 or 8 different types of night guards to accommodate different types of situations. We sometimes do double night guards. And instead of having them made in acrylic, we have them made in a special lab in nylon. And they're just thin and they don't break and they're incredible. And they have plateaus in the front and they just slide together in the front. They're fantastic. No time to talk much about them now, but those are fantastic for the heavy clenchers. No one has destroyed those on me yet, even the heaviest clenchers. We go
Excellent.
through that in the course. They're in the course.
Now, Ramesh has asked, are the courses online or on site? They're online, aren't they?
They're online, so they are. You go to the site. They're based on a platform that's called Learn Worlds. This platform is made for teaching, and so you go to the course and they're accessible online. And when you buy the course, they're accessible for 1 year. And if you want to renew, I'm not going to argue. I won't charge you a second time. I want you to listen to the course. So I will give, if you have access for 1 full year. If you're not done, send us an email. We'll give you another code, and we're not going to ask any questions, and we're not going to ask for more money. That's not our way of doing things.
And you'd mentioned to me that if they purchase the first 2 courses, they get the third course for free.
Yes, yes,
So that's
yes. The first course is $12.95 US. Again, I don't sell the course telling this to people, but the return on investment is like dentists that come to my course, they pay much more for the live course, of course. And it's 50 to 100 times the return on investment in the first year because now they've got their hygienist taking the impressions, they're doing the delivery in the hygienist room, or they're doing 10-minute deliveries instead of 1 hour deliveries because things are coming back from the lab. There's a learning curve. There's a learning curve from the lab. I think I don't want to talk too much, but I think Michael, do you want to say something? Or are you going to be offering them? Anyways, we've discussed this. Don't know if it's going to happen yet, but there are a few trained labs out there that know how to do them, and it's just 10-minute delivery, so it's taking no time. And typical in Canada, people typically charge $800 to $900 for a night guard. These are sold for $1,200. I charge $1,650 because my record is high, so and I mean my statistics are high, so I can charge more, and they come to me specifically for pain problems. But typically, people would charge $1,200 for something that basically costs them 220 minutes worth of time. So it's it's just high profit. But again, I don't want you really doing it for that. I want you to do it because you're rendering an excellent service to the patient. This is a win-win situation. You make better night guards, you build your practice, you build your reputation. People like you if you can do a good night guard compared to the other ones they've had. And it's just a fantastic practice builder because it's win for the patient, win for you. And anyways, you understand what I'm saying.
Excellent, excellent. Well, I've put the link back into the chat there again, starting with basics.com, and then there's /link/ capital DNT.
And if you use that code, we know that you've been on this lecture and you know you've come through David and Michael.
Excellent, excellent. That's great. And Alain, this has been recorded, so it'll be for those who have missed it, they'll be getting a notification. For those who want to watch it again, they'll also get a notification to watch it again on the Advanced My CE platform. So that's great. Do we have any last questions from anybody before we let Alain go to bed, because it is coming up to 10:30 over there now?
That's about bedtime.
No more questions. So thank you everybody for being on the webinar. And Alain, thank you very much for presenting a very detailed and comprehensive course. I love the videos of the joints moving and that healthy tissues look great. So appreciate your time tonight, Alain, and thanks very much.
And thank you for the opportunity to present this. I love sharing this, and it's just, again, I've been sharing this for 17 years and I love doing it, and I hope people get something from it. So thank you for the opportunity.
No, thank you. Thank you. Thanks, everybody. And we'll be in touch with when the recording's available, as well as also what we've got planned coming up in the near future on the Advanced My CE platform. And if you want to join Advanced My CE and become a member, it's free. Joining is free at the moment, and there's lots of opportunities to collaborate and to be educated and to save on education and save on product purchases as well there. So just go to Advanced My CE, spell it as it sounds, all one word, advancedmyce.com, and just follow the prompts there to join. Alain, thanks so much. Have a good